Good evening, everyone. Welcome back to the JMitra Scientific Webinar with our esteemed speaker, Professor Ashok Rattan. Today, we'll be touching on a topic that could probably save your life, save lives of people around you, because it pertains to the laboratory testing for the dengue virus. These are the latest guidelines that we will be sharing with you, which have been issued in April 2025 by the World Health Organization for the laboratory testing of dengue virus. India is a country known for being endemic for dengue. So it's important that we take dengue seriously. And it is my privilege and honor to have with us today Professor Ashok Rattan, an esteemed microbiologist and an academic leader in the thought process on microbiology. Professor Rattan, over to you, sir.
Thank you very much. Good evening, everybody. As you see here, that in April 2025, WHO released interim guidance for the laboratory testing for dengue virus. Dengue, as you know, is a growing global health problem. Over the past 2 decades, incidence has increased dramatically. Globally, cases have been doubling every year since 2021. Dengue is being diagnosed in previously unaffected regions of the world. In 2023, WHO declared dengue a global emergency and have launched a global surveillance dashboard. In 2024, there were 14 million cases with 10,000 deaths in 107 countries, while 75 countries reported 0 cases. A few years back, maybe a decade back, dengue used to be considered as a tropical disease, and it was restricted to the tropics. But as you see now, with global warming and the condition becoming suitable for the growth of the vector, it's now spreading to many locations which previously did not have dengue. In the dashboard, you find that in Brazil, there are more than 3 million cases, while in India, there have been 49,000 cases, which is much lower than what it was in the previous year. But a global study looking at the burden of disease indicated that in India, dengue has been increasing manifold from 1990 to 2019. And it's not only dengue infection which has increased or dengue disease which has increased, but the disability adjusted life years have also increased. Dengue virus is a member of the orthoflavovirus genus in the Flaviviridae family. This is the causative agent of dengue. Its genome is a single-stranded positive sense RNA that encodes 3 structural proteins, that is capsid C, membrane M, and envelope, and 7 non-structural proteins. Dengue is classified into 4 distinct serotypes, 1 to 4, which shares approximately 65% of the genome, and each serotype incorporates several genotypes. Infection with one dengue serotype is thought to provide lifelong immunity against that serotype, but only short-term cross-protection against the other serotype for approximately 8 to 12 months. This is showing the structural proteins and the non-structural proteins. The vector, dengue virus is transmitted by a vector known as Aedes aegypti and now Aedes albopictus. The primary mode of transmission is by these two mosquitoes. They are also known as tiger mosquitoes because the stripes that are there. The mosquito usually breeds in fresh water and has a flying range of about 500 meters. It bites in dawn and dusk. The infection that Aedes can transmit besides dengue is chikungunya, yellow fever in Africa, in South America, Zika, and Rift Valley fever. And you can make out between whether the mosquito is Culex, mosquito is Aedes aegypti or Anopheles by looking at the angle. Anopheles will rest at an angle to the surface, while Aedes is parallel to the surface. Mosquitoes overall in the tropical region are transmitting various infections, and in fact, Gates Foundation once brought out a poster indicating that mosquitoes kill more human beings than even men. The clinical features could vary. Dengue infection presents with a broad range of clinical manifestations, from mild to severe illness. Diagnosis of dengue based on clinical symptoms alone is unreliable due to the wide spectrum of non-specific symptoms during the febrile illness. There is primary and secondary dengue infections which exhibit a distinct diagnostic pattern. Specific and sensitive diagnostic tools are available that are suitable during certain phases of diseases because it's a dynamic disease. And there are three stages in clinical features. First phase is the febrile phase, where there's headache, fever, pain behind the eyes, mouth and nose bleeding, muscle and joint pains, vomiting, diarrhea, rash. These after febrile phase for 3 to 4 days, there is the stage known as critical phase, where there may be hypotension, pleural effusion, gastrointestinal bleeding, and ascites. Once a person has overcome this, and during this time, the danger is the maximum. After that, there is recovery. In the recovery phase also, as the fluid is reabsorbed, there may be fluid overload leading to seizures, altered mind, slow heartbeat, and itching. So there is primary and secondary dengue infections. Primary infection, of course, will be only one, but since there are 4 serotypes, there could be 3 secondary infections. So the primary infection is normally mild or without any symptoms. Only when a second infection occurs that there's a risk of serious illness or even death. Since there are 4 genotypes, infections only provide genotypic specific immunity. The first infection would be mild, sometimes unrecognizable. Then it rarely develops severe disease and recovers. Second infection is the one which can lead to either shock or hemorrhage, and this appears to be due to antibody-dependent enhancement, and that is the key feature of the pathology of dengue. It's been explained in the sense that dengue enters the cell and infects the cell, then is presented to the B cells, and antibodies are, are produced, which will then help to clear it. On the other hand, if antibodies are already present and these are not neutralizing antibodies, then they would bind to the virus, and instead of binding through the FC portion, will bind by uh, instead of the FC portion, it will bind through other regions. As a consequence, the viral load in the macrophage will increase and will not be neutralized, leading to copious amount of virus being produced.
Plasma leakage is a process in which the protein-rich fluid component of the blood leaks from blood vessels into the surrounding tissue. Plasma leakage is the most serious complication that distinguishes dengue from severe dengue. For some dengue patients, as fever begins to disappear, severe dengue will develop.
So severe dengue is when the fever has decreased. So the fever itself is a warning signal, but it's not the fever. Fever will lead to dehydration, but so diagnosis must be made, and it's been seen that with early diagnosis and adequate treatment, the mortality is 1%. But if diagnosis is not made of dengue and treatment is not given, then the mortality can be as much as 20%. Dengue, as I've already explained, would have three phases. After the incubation period, there'll be viremia. Viremia starts before clinical features appear. After that, this is the febrile phase where viremia is also present. After that, the virus disappears and the antibodies appear. So if the person comes early, then it will be in febrile phase. And if the person comes after 7 days of in starting of the clinical features, then the likelihood is that the virus has already disappeared. And instead of that, you have the critical phase, which will have antibodies. But when the virus is there and the virus is multiplying, it produces, as I had indicated, a number of proteins, and one of them is NS1 antigen. NS1 antigen is a surrogate of the virus being present. And normally, as you see in the chart here, it survives for slightly longer. Even after the virus has disappeared, NS1 may be present. In the primary stage, after the mosquito has bitten and there is an incubation period of varying from 3 to 9 days, the virus starts appearing. Then once the virus is multiplying, it produces the protein. NS1 is one of the proteins that is present, and there is clinical features. Once the fever decreases, then that is the time when there's risk of shock and hemorrhage. So the second stage is the risk is the critical phase, and once that is over, by that time you would find that IgM as well as IgG antibodies are present and a person starts recovering. On the other hand, when there's secondary infection, the IgG antibodies are already present, and they would rise faster after the virus has increased in number, and this is a different serotypes than the previous one, but IgG would be there. So if you find IgG and the virus, then you can be sure that you're dealing with secondary infection. But since virus is difficult to detect unless you do RT-PCR, what is normally done is NS1 and IgG. If both of them are present, then it's likely that it's a secondary infection. Subsequently, IgM will appear. So here, IgM will appear later. So it's critical to know when the symptoms first appeared and when is the sample being taken, how many days have passed after the appearance of symptom that you're testing, because the analytes that you'll be testing, those are viral RNA, NS1, IgM or IgG, are dynamic, and depending upon how many days have passed from the appearance of symptoms, you would be able to expect that they be present or they may be absent by that time. So if the diagnosis is of acute phase and the patient gives history of less than 7 days post onset of symptoms, direct virus detection of DNA of the dengue RNA virus is possible using nucleic acid amplification tests that are highly sensitive and specific, and many RT-PCR assays have been described. During the acute phase, NS1 antigen can also be detected. This NS1, it could be detected by ELISA, and now we also have rapid diagnostic tests which make detection of NS1 easy and convenient. And this, in the primary infection, this lasts for anywhere between 6 to 9 days. In secondary infection, it lasts for slightly less because antibodies are already present. So NS1 in secondary infection would last 6 days rather than 9 days. If more than 7 days have passed, then it will be not proper to go in for RT-PCR or detect IgM. Detect NS1. What you should then detect is IgM, which will show recent infection, because after a few days, IgM will disappear, while IgG will appear later, will persist for long. If IgG is present, only IgG is present, and there's indeterminate history of how many days that initial infection occurred, then it's likelihood that it's a late infection. For surveillance, the virus should be isolated. Isolation is no longer practiced for making a diagnosis, but for surveillance, you might want to do either the reference lab might want to do either isolation of the virus or a test known as plaque reduction neutralization test, PRINT, to identify what serotype specific neutralizing antibodies are present. They might also want to use multiplex real-time PCR for serotype differentiation, but the caveat here is that they must get the sample within 7 days of starting of the infection, if of the symptoms. If they don't get, then they're more likely to get negative results. Once the virus has been isolated, then they might want to do sequencing to identify what genotypes and serotypes are occurring. So once again, to repeat, primary infection and secondary infections have different dynamics and they have different meaning. Primary and infection, you would find if the sample is collected within 7 days, then viral RNA or NS1 are the two tests that can be carried out. If it is after 7 days, then it's best to go in for NS1. If it is between 5 and 7 days, then NS1 and IgM could be tried. And if it is beyond that, maybe IgG and IgM both need to be looked at. If it is secondary infection, Secondary infection, you would find that in the first 6 days, virus is present and NS1 is present. In that case, you would be able to, this is what can be detected. IgG will already be present, and IgM will appear by the 6th day. So looking at what analyte is present, you should decide which test you would like to use. Remember that all stages of dengue infection can be serious, but normally the danger from fever is dehydration. And in fact, there was a webinar I was attending from a consultant from Malaysia, where she said that it is now, for the last 10 years, it's been their policy that they will do rapid testing during the fever stage, and then if it is positive, they'll put the child or the adult on coconut water and by oral. And coconut water, rehydration with coconut water will prevent many of the problems associated with dehydration, which is common during the febrile phase. If it is a secondary infection, chances of uh, chances of serious or severe dengue are more, and these could be either a bleeding tendency, that will be known as dengue hemorrhagic fever, or there will be shock, so dengue shock syndrome, and that normally occurs 3 or 4 days after the onset of clinical features, and there are clinical signs which can make you suspect that the person is in the critical phase and is going in either for hemorrhages or for shock. Once that period is over, then the fluid which had gone into the tissue is reabsorbed, and the reabsorption of fluid can lead to its own problem. So you have to look out during during the acute phase for dehydration, during the critical phase for shock or organ impairment, and during the reabsorption for during the recovery phase for reabsorption and fluid overload. There was a study which was done to differentiate secondary and primary dengue using IgG and IgM ratio in early diagnosis. And in this, they had taken 114 patients confirmed by RT-PCR to have dengue. On day 2 of the illness, IgG and IgM values were obtained by ELISA, and IgG and IgM rate was calculated. They found that most of the cases had dengue 1 serotype. 66.7, that is 76 patients had secondary dengue, and secondary dengue had higher mean temperature, lower platelet count, and higher percentage of severe dengue, that is dengue hemorrhagic fever or dengue shock syndrome, 38.2 versus 2.6%. And they could differentiate, and they noted that in the first week of infection, RT-PCR was better than IgM for diagnosis, and it was reverse in the second week, because as I'd already indicated to you, that virus will disappear by the second week, while IgM would have started about the 4th day or so, and IgM will be prominent then. The IgG by IgM ratio, which you calculate on the 2nd or 3rd day, you would find if it is more than 1.1, then it has an accuracy of 97.4%, a sensitivity of 97.4%, and accuracy of 67.5% to differentiate between primary and secondary dengue. And as I've been indicating, and as this paper also indicates, that the chances of severe dengue or during critical phase is more in secondary dengue than in primary dengue. Of course, they still got 2.6% had severe dengue during the primary infection also. It's likelihood that the primary was missed because it was asymptomatic, and what they were dealing was secondary. All right. So dengue virus infection is a self-limiting febrile illness with symptoms ranging from asymptomatic to severe multi-organ dysfunction. It is estimated that 40 to 80% of infection caused by dengue are asymptomatic, and fewer than 5% of all dengue patients develop severe life-threatening conditions. Severe dengue can manifest in both primary and secondary infection. However, the likelihood of severe disease may be elevated in secondary infection due to antibody-dependent enhancement. With early diagnosis and appropriate symptomatic treatment, mortality is 1%. Severe dengue may have 2 to 5% mortality, but undiagnosed and untreated dengue would have a mortality of as much as 20%. Since there is no specific treatment and the vaccine is not yet licensed in India, though 2 vaccines are available in other parts of the world, it's been suggested that prevention should be avoid going out at dusk or dawn when mosquitoes are more likely to be active. When we go out during the monsoon, we should be covered. We should not expose any part of our skin, and we should wear protective clothing. We should use insect repellent. We should remove standing water because Aedes grows in fresh water rather than stagnant water. We should stay in places with air condition and window screens and sleep under a mosquito bed net. WHO has given definition of a suspected or clinical compatible case of dengue. Suspected case will be a person who lives in or has traveled in previous 10 days to area, probable case, and then confirmed case. The point that has to be made is due to the lack of specificity of clinical diagnosis, laboratory confirmation is necessary to definitely diagnose dengue infection. So dengue could be suspected clinically, but it must be a definitive diagnosis can only be made once it is tested in the lab. There is clinical diagnosis also available, dengue without warning signs, dengue with warning signs, and severe dengue. Dengue with warning sign is any case of dengue that presents with one or more of the following signs as or preferably after fever drops. There's intense and sustained abdominal pain or tenderness of the abdomen, persistent vomiting, lethargy or restlessness, fluid accumulation, mucosal bleed, postural hypotension, liver enlargement, progressive increase in hematocrit. These are all signs of warning that the critical phase is going to be severe. And severe dengue will be any case of dengue that has one or more of the following clinical manifestation: shock or respiratory distress due to severe plasma leakage, severe bleeding as assessed by the attending physician, severe organ involvement where there's liver damage and myocarditis. This is from a previous WHO guidance where they indicated that criteria for dengue plus minus warning signs and criteria for severe dengue was explained, that these are the criteria that clinicians can use while dealing with clinically dealing with patients. But if possible, a lab diagnosis must be obtained. This is a summary slide of the clinical part. As you say, day of illness is very important. Temperature, sudden rise of temperature is one of the characteristics. By the third or fourth day, the fever will subside. In India, we feel that fever is bad, and once the fever subsides, we rejoice. But in dengue's case, fever will lead to dehydration, so hydration is required. But the severe part of dengue is during the critical phase, which normally occurs when the fever has decreased. And here, the decrease in fever will be associated with bleeding from the gums or bleeding in the skin or shock syndrome. And laboratory simple test of hematocrit on CBC would be able to give you a guidance. Platelets, I think worldwide people know that platelets must be counted in case of dengue, and serological test as well as virology or NS1 will detect the virus directly, or look at IgG and IgM as an indirect evidence of infection. So in dengue fever, during the febrile stage, there is high rise of temperature, sudden rise of temperature, which remains high for 3 to 4 days. Then the fever subsides. What matters then is, and so during this time, there could be not only dehydration, but also coagulopathy, because then it depends upon what is the levels of hematocrit or platelets. If the hematocrit, that means there's no leakage of plasma and no decrease in platelets, then the critical phase will pass uneventfully and there will be recovery. But if during the critical phase there's decrease in plasma or increase in hematocrit, there would either be bleeding if there's decrease in platelets, or there'll be shock syndrome if there's increase in hematocrit. So the 4 alarm signs are 4 criteria for dengue hemorrhagic fever is fever, hemorrhagic manifestation, excessive capillary permeability, and platelets less than 100,000. Alarm signs are severe abdominal pain, prolonged vomiting, abrupt change from fever to hypothermia, change in level of consciousness, or irritability. Initial warning signs will be disappearance of fever, drop in platelets, and increase in hematocrit. And when do we say that the patient has developed dengue shock syndrome? It occurs 3 or 4 days after onset of symptoms. So the characteristics of ideal diagnostic test will depend upon what is the purpose that you want to do the test. If it is early diagnosis, then you want a test which is easily available and reliable, which is inexpensive and ready and easy to use and stable at various temperatures, and will help you differentiate between primary and secondary. If it is for surveillance, which NCDC and reference labs do, the surveillance would be, first priority would be whether it's positive as soon as possible after onset of symptoms to provide early warning. It should be highly specific. It should determine dengue serotypes. And second priority would be it should distinguish between primary and secondary infection. It should be able to handle high capacity. It should have long shelf life and accept non-invasive samples like saliva or urine. And if we want to support vaccine efficacy studies, then in that case, we should provide virological diagnosis of dengue virus infection during the febrile phase, distinguish between dengue and other flaviviruses, distinguish between dengue serotypes, distinguish between first and subsequent infection, and provide correlates of infection or correlates of protection. So WHO has brought out this algorithm which says that if you suspect a dengue case, the first thing you must ascertain is how long has it taken since the onset of symptoms for the patient to come to you. If it is less than 7 days, then the option that is available to you is do RT-PCR or do NS1. NS1 antigen is a surrogate of RT-PCR, and this you can do by ELISA or by doing rapid diagnostic test, that means lateral flow. If it is positive by RT-PCR, then it is confirmed. If it is positive by NS1, whether detected by ELISA or rapid test, then it's confirmed. If it is more than 7 days, then in that case, you have the option of doing NS1 and IgM, because as I indicated, that in primary infection, NS1 will last for 9 days. In secondary infection, NS1 will last for 6 days. In primary infection, IgM might appear by the 3rd day, and then by 7th day, it'll peak in about 2 weeks' time. So when it is between 5 to 9 days, then NS1 and IgM would be done either by ELISA or a rapid diagnostic test. Though I do notice that if you have IgG along with it, you would be able to differentiate between primary, where IgG will not be present, or secondary, where IgG will be present along with NS1. So as you notice here, this is the latest guidance from WHO in April 2025, and they're indicating that you have an option for diagnostic purpose to use NAT testing, NS1 by ELISA or rapid test, and this is all that you need to do. So of course, if it is positive, then it's easier, then life is easier. If it is negative, then there's a long list of tests that you must do. A team of Indian Association of Critical Care had indicated that whenever there's fever during monsoon in tropical conditions like India, we should also rule out not only dengue, we should test for dengue, but also rule out malaria, scrub typhus, chikungunya, leptospira, and typhoid, because each one of them have similar kind of symptoms. Now, dengue can be the samples which are suitable for testing for various purposes, could be serum, could be plasma, could be whole blood without anticoagulant, whole blood with anticoagulant, capillary blood, urine, and CSF. If you have nucleic acid testing, it is highly sensitive and specific. It gives you results on the same day, and it's possible to automate it, and it will identify whether which serotype is present. But the limitations are that it is going to be useful only in the first 7 days, and so you must be clear whether when the symptoms first appeared and whether the sample is collected within 7 days or not. And of course, it's costly and it is restrictedly available. But there's a point of care testing which has been made available, which is a cartridge based, and they have two types of cartridge. One is which will detect all the 4 serotypes of dengue, but there's a cartridge which will also detect arboviruses, which are normally prevalent in that area. And the mosquito might transmit the same infections. And the test is simple. You take the cartridge, put the sample in, and in a few in a few minutes' time, you would have the result, and result would indicate whether there's single infection or multiple infections. In their reference lab, they might want to do next generation sequencing because that will indicate what genotype or serotypes are and other sequences that are occurring with what mutations are occurring in the RNA virus. But for diagnostic purposes, a rapid test using NS1 antigen seems to be the most attractive, which WHO has now permitted, which says that for patient management and outbreak investigation, you should do NS1 antigen. NS1 is highly conserved, low risk of virus evolving, affecting epitopes, easy to perform, and point of care testing available. Can use capillary or finger prick blood, rapid results, so that you know straight away whether you are during the fever, whether you're dealing with a person having dengue or not. The limitations are that it detects acute phase of infection 7 days, lower sensitivity compared to NAT or ELISA, and potential for false negative when secondary infections, because here, because of pre-existing antibodies, the NS1 antigen would be at lower titer and for shorter duration. But simple tests are available, which is 1 drop of blood, 1 drop of buffer, and in 20 minutes time, you have the results.
This is your dengue home test kit. It includes a test device, an assay buffer tube with nozzle, a sample dropper, swab, and a lancet, a disposal bag, and an instructions manual. Rub your fingertip with a swab. Gently prick the fingertip with the lancet. Use the sample dropper to draw the blood into it. Add 1 drop of whole blood sample into the sample bed of the test device. Add 1 drop of assay buffer into the same sample well. Allow reaction to occur for 20 minutes and give the result. The result is positive when 2 distinct green lines appear in the control region C and test region D. The result is negative when only 1 big colored line appears in the control region C. The result is invalid when neither control line C nor test line D appears, or only line D appears. Repeat the test again with a new line.
So the benefits of point of care testing for dengue fever during monsoon season is that it's a rapid diagnosis for timely intervention, accessibility in resource limited settings, decentralized testing for outbreak control, enhanced patient management and triage, and cost effectiveness and scalability of testing. There's also ELISA, which many authorities feel are better because it's more sensitive. But NS1 ELISA, the advantage is that it's highly conserved, the same advantage that you get there. And the limitations are it will detect for the first 7 days, But the other limitation are that normally ELISA takes about 5 hours, and you normally have a tendency to batch it because 96 tests can be done at one go. So batching it delays, and once you've started, then you cannot have random access. On the other hand, if the sample has come between 5 days and 10 days or 9 days, then instead of restricting yourself only to NS1, you should look at NS1 as well as IgM. That will give you the coverage between between the time interval that might have passed, and NS1 may be present or IgM may be present. If it is too early, then NS1 will be positive, and if it is slightly late, then NS1 would have disappeared, but IgM would have been positive. And this could be either by the rapid test or you could do ELISA. There's also IgM and IgG ELISA rapid test. This is more for follow-up for older persons who have come later, and this can also be available as ELISA. For reference lab, because print is no longer done for diagnostic purpose. It is mostly for outbreak investigation and surveillance by the reference lab. And this is the steps involved because it involves cell culture, it involves neutralization test, then it involves 7 to 10 days before the results come. So it has no diagnostic value. So this is how you would be able to make out what is happening depending upon whether you've done PCR or NS1 or IgM and IgG, NS1 and IgM, various combination and permutation will give you advice on what is the status of infection. And just keep in mind that by using we moved from latex and now mostly we use ELISA. A rapid test have a sensitivity of 1 nanogram, while ELISA would be more sensitive and will pick up 500 picogram. But chemiluminescence, bench lab chemiluminescence is now available, which pick up 1 picogram. So what we would have missed by using ELISA, we would pick up by using chemiluminescence. This might make even testing non-invasive samples possible. So it could be, though evidence still have to be collected, but it is clear that reference lab, instead of using ELISA, should use chemiluminescence. And for diagnosis, if you are trying to use non-invasive samples, then chemiluminescence rather than ELISA for NS1 may be more useful. So the advantage between ELISA and CLIA would be that the sensitivity of ELISA is good, but sensitivity of CLIA is excellent. That would be 30 minutes to 5 hours. Batching is not necessary because in CLIA you can do random access, and the only drawback is that it's slightly costlier than ELISA, but it's suitable for high throughput when you have a lot of samples to be carried out. Then CLIA may be better than ELISA. So there are various considerations which will go in selecting which test you would like to use. It will depend upon the methodology, test performance, ease of use, storage and shelf life, quality of products and registration, and cost effectiveness. There are routine tests which also need to be carried out. I've already mentioned that platelets will decrease and packed cell volume or hematocrit will increase. So if you monitor right from the day you make a diagnosis of dengue and subsequently every alternate day, that what is the status of platelets, or more frequently, what is the status of platelets and what is the level of hematocrit. Liver function test and kidney function test should also be monitored. There was a paper based from Australia based on study which was carried out study which was carried out in Vietnam, where they looked at four risk factors. One is vomiting, NS1 antigen, platelet count, and how many times over the normal the AST was. And they gave various points to it. They found that they found that it had a negative predictive value of 99%. If you gave marks to each one of the four parameters and total them up, if it was less than 35%, then a person could be allowed to go home, because chances of severe dengue occurring in that person is less than 1%. The positive predictive value means those who you keep down for your observation, they would have severe dengue in about 10% only. So it has low positive predictive value, but very high negative predictive value. What you need to do is find out whether a person is vomiting, what is the platelets number, whether it's NS1 positive in rapid test or not, and what is the AST level, and give points to each one of them. Here, as you notice, that if it is more than 35, then the chances of severe dengue is there. Dengue has been recognized as one of the 10 threats to global health by WHO and by most other authorities, and they suggest that prompt identification of dengue virus can guide clinical management and outbreak response. Yet, laboratory diagnosis is complex, costly, and lacks consensus on performance evaluation. And these guidelines were developed to answer this point. Interim guidance by WHO synthesizes current evidence on dengue laboratory testing and diagnosis. It is intended to provide practical and useful guidance for laboratories, countries, and stakeholders implementing dengue diagnosis in the context of global um, emergency which WHO has declared for dengue. If you use these guidance, it will be useful. I thank you for your attention.
Thank you very much, Professor Rattan. It's one thing to have the guidelines available from the WHO. I mean, they've always been there since April 25, but it's another thing that to actually have them explained to you, in detail. So, what is the one big thing that you think that the WHO has changed over the last set of guidelines in this guideline? The one big thing that everybody in the lab must be aware of.
I think the major change has been acceptance of rapid diagnostic tests, because wherever I would go, I would hear people murmur that rapid tests are not to be used. Uh, though in 2011, there was a study which was carried out in Singapore. There was an outbreak, there was a huge outbreak of dengue there. And that's the time when they were doing immunofluorescence, they were doing culture, they were doing PCR. And along with that, they started doing the dengue DO test. And they found that DO test performed as well as culture, as well as PCR, as well as IG, as immunofluorescence. But it was the test results were available in 30 minutes time. As a consequence, actions could be taken and mortality could be decreased. So since then, at least scientists in Singapore had been advocating that rapid tests have a meaning. And I think JMitra has brought out home test so that you could do, if uh, at the benefit of your own house, in the security of your own house, at the own time, you can do the test yourself and know whether you have dengue or not. That is one of the main advantages, and WHO has accepted that this should be one of the mm, one of the algorithm, one part in the algorithm which they are permitted now to be used, and this will be adapted worldwide and used. I think that's the major change. The other change I foresee is that the reference labs would normally be going for ELISA instead of ELISA, which they do at the moment, they would use CLIA, because that will be, and those who already have CLIA may want to experiment with finding out non-invasive samples to see whether in children they can rapidly screen for the presence of dengue infection.
Thank you very much, sir. Thank you all, ladies and gentlemen, for attending this webinar. We will see you on the coming Friday, where we talk with Kaho and Professor Rattan in a panel discussion with several experts on the subject of infectious disease testing, TTIs in blood centers. Till then, thank you very much. Over and out. Good night. Thank you, sir.